Okay, good afternoon, everyone. Welcome to the Symposium 3, which is the panel discussions on the role of cardiologists and cardiovascular healthcare professionals in tobacco control. These sessions is a bit very quite unlucky that we cannot have the Zoom for the speakers because because of the difference of the time zone. So we're gonna have these symposiums on the video. So if you have any questions about this session, you can drop your questions on the chat box, and we'll pass the your question to the speakers. And please drop your questions along with your email so that we can pass your question to the speakers, and the speaker will answer your question later. These sessions, we are very fortunate that have the Dr. Esti Nurjadin from Indonesia to be the moderator for the sessions, and also we have 4 speakers from 4 different countries that are going to share with you about the cardiovascular health and the tobacco. We have Professor Bianco from Uruguay and Professor Hasegawa from Japan, and Dr. Mamit from United Arab Emirates, and also Dr. Aurora from India. Okay, I think we can start the session now. Enjoy the video. Okay.
Hello to the panelists and to all participants. Welcome to the 13th Asia Pacific Conference on Tobacco or Health. Today's session is brought to you by the World Heart Federation. The topic of this symposium is the role of cardiologists and cardiovascular healthcare professionals in tobacco control. Cardiovascular disease remains the world's #1 killer. Tobacco use and secondhand smoke are among the leading causes of cardiovascular diseases globally. However, in spite of the known harm of tobacco use, public awareness on the relations between tobacco and heart disease remains low. In the light of the ever-expanding tobacco epidemic and the COVID-19 pandemic, cardiologists and other healthcare professionals have a crucial role to play in preventing and reducing tobacco-related mortality and morbidity. In this session, we will discuss the effects of tobacco use and secondhand smoke on the cardiovascular system, also the relations between tobacco and coronary heart disease, and the benefits of smoking cessation on heart health. We will also discuss the synergy between tobacco and COVID-19 on cardiovascular health. In addition to that, we will hear a presentation on the WHF roadmap on tobacco control and discuss what are some of the potential obstacles in tobacco control and what are the potential solutions available out there. My name is Esti Nurjadin. I'm the chairman of Indonesia Heart Foundation and also the board member of the World Heart Federation and the president of NCD Alliance Indonesia. I'm here today to moderate the discussion session. Before we begin the panel discussion, I would like to invite Professor Eduardo Bianco to give a welcome address on the topic. Eduardo is the regional coordinator for the Americas of the Framework Convention Alliance, and he is also the chairperson of the WHF Tobacco Expert Group. He is a cardiologist specializing in tobacco addiction. He has made major contributions to the development and implementation of WHO FCTC in the Americas. Eduardo, the floor is yours.
Thank you, Esti. Distinguished participants, ladies and gentlemen, I have the great pleasure to welcome you on behalf of the World Heart Federation to this symposium on the role of cardiologists and cardiovascular healthcare professionals in tobacco control. Cardiovascular diseases remain the world's #1 killer, causing over 18.6 million deaths every year Tobacco, as a leading cause of cardiovascular diseases, contributes to approximately 70% of all cardiovascular disease deaths. In spite of the known harms of tobacco to heart health and the availability of evidence-based solutions to reduce tobacco-related death and disease, public awareness of the link between tobacco and heart diseases remain low. Tobacco kills more than 1 million people annually, more than 7 million as a direct result of tobacco use, and 1.2 million from secondhand smoke. The smoking prevalence in Asia-Pacific region remains high, and the region has been a prime target of the tobacco industry for many years. The World Heart Federation champions cardiovascular health for everyone and represent more than 200 heart foundations, scientific societies, and patient organizations, many of which are located in the Asia-Pacific region. For many years, World Heart Federation has been a global advocate in the fight against tobacco, partnering with relevant organizations, supporting the tobacco control initiative of our members, developing the WHF roadmap for tobacco control, and in 2018 establishing a tobacco expert group. The health and economic burden of tobacco is immense, yet preventable. In light of the ever-expanding tobacco epidemic and the COVID-19 pandemic, we believe that cardiologists and other healthcare professionals have a crucial role to play in preventing and reducing further tobacco-related mortality. In this session, we will discuss the effects of tobacco on the cardiovascular system, the addition of the COVID-19 pandemic into the equation, and the common challenges encountered in tobacco control as well as their solution. We will also provide a short presentation on conflict of interest and tobacco industry interference in science. I would like to thank the organizers of the Asia-Pacific Conference on Tobacco or Health for giving us the opportunity to discuss this important topic with you today. I wish you all a most enjoyable and informative symposium. Thank you for your participation. Now, we are going to see a short video from World Heart Federation on tobacco breaks heart.
Do you have a deadly relationship with something you regularly put in your mouth? Smoking, vaping, chewing, no matter how you use it, tobacco will clog your arteries, which can cause heart attacks and sometimes even death. Nearly 2 million people die every year from heart disease caused by tobacco use. A few cigarettes, exposure to secondhand smoke, and even e-cigarettes increase your risk of heart disease. We all have a part to play to save our hearts. Health workers can inform people of the dangers they face. Governments can develop smoke-free policies, ban advertising, raise taxes, mandate warning labels, and provide services to help people quit tobacco. And you can quit today and help your loved ones to quit once and for all. After you quit, your body will get healthier and healthier every day. After just 15 years of no tobacco, your risk of heart disease will be reduced to that of someone who never smoked at all. Together, we can create a healthier, tobacco-free world.
Thank you, Eduardo, for the opening remarks. Now let's move on to the discussion session. We are very lucky today to have distinguished speakers that are here with us for this session. Of course, Professor Eduardo Bianco is one of the speakers, but we also have Dr. Koji Hasegawa, Dr. Wael Al-Mahmed, and Professor Monica Arora. Dr. Koji Hasegawa is the Director of Division of Transnational Research at National Hospital Organization, Kyoto Medical Center, and he is also the member of WHF Tobacco Expert Group. Dr. Wael Al-Mahmed is the immediate past president of Asia Pacific Society of Cardiology. He is also a consultant cardiologist at the Cleveland Clinic, Abu Dhabi. Professor Monica Arora is the Director of Health Promotion Division at Public Health Foundation of India and President-elect of NCD Alliance. She is also a member of the WHF Advocacy Committee. She is a public health scientist specializing in NCD prevention and control, with focus on tobacco control. Professor Monica is one of the authors of WHF Roadmap for Tobacco Control. First topic, tobacco and cardiovascular health. If I may, I would like to ask the question to Dr. Weil first. As we all know, tobacco is the leading cause of cardiovascular disease. My question is, can you tell us more about the effect of tobacco use and the exposure of secondhand smoke to cardiovascular system? Is there a safe level of tobacco exposure, Dr. Weil?
Thank you very much for that question. It's been well documented in a lot of research for many years that smoking, both ordinary smoking and passive cigarette smoking or secondary smoke, affects the cardiovascular system. Smoking and passive or secondary smoke can affect the cardiovascular system in many, many ways. It can cause heart attacks or myocardial infarction. It can cause peripheral vascular disease, and it can cause stroke. With regards to heart attacks or myocardial infarction, this usually results as a result of a thrombosis or a blood clot in the coronary artery leading to damage to the heart. In young patients, we see this quite commonly, particularly in patients less than 45 years of age. The number of deaths or from cardiovascular disease in young patients less than 45 years of age is quite high. It can go up to 35% of cardiovascular morbidity and mortality. And what we see in these young patients is a thrombosis, usually on arteries that do not have plaques, so just a clot, and causes the heart attack in these young patients. Young patients can also suffer from peripheral vascular disease, thrombosis and atherosclerosis of the peripheral arteries, and present with intermittent claudication. They can also present with stroke or thrombosis of the cerebrovascular system. The acute effects of smoking are also well known. They can increase the blood pressure, which can also lead to stroke. They can also lead to a rapid tachycardia, and the patient feels palpitations. These same effects are seen from passive smoking or secondary smoking or secondhand smoke, and obviously not as much as smoking per se, but are also seen with passive smoking. Is there a safe level? No, there is no safe level of smoking. The best thing to avoid cardiovascular complications is to stop smoking totally. Thank you.
Thank you, Dr. Weil. Yeah, we haven't paid much attention on the secondhand smoke because they can cause the same diseases as you mentioned before as the tobacco user. Next question is for Professor Eduardo. In 2020, the World Heart Federation, in collaboration with the WHO and the University of Newcastle, Australia, published a paper about tobacco and coronary heart disease. Can you share with us some of the findings from that article?
Sure, SD. The new knowledge summary on tobacco and coronary heart disease is a WHO document prepared jointly with the World Heart Federation and the University of Newcastle. It has been prepared with the objective to address misperception by summarizing the current evidence on tobacco, coronary heart disease, and public health. It is intended as both an informational guide and as an advocacy tool. The paper reviews the impact of tobacco on the pathophysiology of the coronary disease, the relationship between consumption and exposure to tobacco, to smoke and cardiovascular damage, addresses the smokeless tobacco and new tobacco and nicotine products, as well as the impact of population-based intervention and individual intervention. Some of the topics highlighted by this knowledge summary have been addressed by Will in the first comment, but we are also to highlight them again in order to reinforce this idea. First, tobacco use and secondhand smoke exposure are responsible for 1.9 million avoidable deaths from coronary heart disease every year, approximately 21% of the total coronary heart death. And yet, in many countries, the link between tobacco use and heart disease is not well understood. People could be aware of atherosclerotic damage that tobacco causes, but as Dr. Wells said, maybe is less aware of smoking-associated thrombotic damage, which will be the predominant mechanism of cardiovascular damage in young people. And that will be the reason, as Dr. Wells said, why tobacco smokers are more likely to experience an acute cardiovascular event at younger age. The second message is that even smoking a few cigarettes a day, even one a day, or occasional, significantly increase the risk of heart disease and stroke. There is also no level of tobacco smoke exposure exempted from risk of cardiovascular damage. That is an important message. The other message that this summary contains is that if tobacco users take immediate action and quit, their risk of heart disease will decrease by 50% after 1 year of quitting. The brief also shows that smokeless tobacco is responsible for around 2,000 deaths from coronary heart disease per year. We are going to talk about that later. Regarding e-cigarettes, this paper also highlights that these products are not exempted of cardiovascular risk. The toxic substance contained in these products can lead to impaired endothelial function, narrowing of arteries, increasing heart rate, and raising blood pressure. But also, we are going to address this topic in depth later. Smoking cessation intervention improve cardiovascular health and decrease cardiovascular events in a short amount of time. The same is for smoke-free legislation that reduce smoking-related hospital admission for both smoker and non-smoker. And one example is from my country, Uruguay, when in March 2006, we banned smoking in all public places and all workplaces, and suddenly, 1 month to another, it decreases the acute myocardial infarction admission to hospital by 17%, and it maintained it along the time. So this knowledge summary can support regional, national, and local initiatives for the control of tobacco products and the prevention of cardiovascular disease.
Thank you, Eduardo, for your explanation. So occasional smoking is also increasing the risk of cardiovascular diseases. So in spite of the demonstrated harm of tobacco to heart health, people living with or at risk of cardiovascular disease continue to smoke. The question is, I would like to address to Dr. Weil and Dr. Koji. What is the level of awareness regarding the link of tobacco and cardiovascular disease among smokers? And how can we address this knowledge gap? Maybe Dr. Weil can answer first, and then Dr. Koji can comment on that.
We as cardiologists in a busy cardiology clinic or in primary care or in our clinics, we always assume that our smokers are aware of all the cardiovascular effects of smoking. But a number of surveys have shown that actually patients are not aware of the cardiovascular effects of smoking or the cardiovascular morbidity relating to smoking. A lot of them are aware of the smoking and relationship to cancer, particularly lung cancer, but not to cardiovascular diseases. However, in busy clinics, we assume this and we forget to emphasize the fact that smoking is related to cardiovascular disease. The other thing is, in a busy clinic, we don't have time to talk to the patient with regards to cardiovascular disease and smoking. We don't have time to talk about smoking cessation. We only have a short period of time to discuss the patient's problems and medications. And again, this is because we also assume that the patient knows the effects of cardiovascular disease and smoking. We should, to affect this knowledge gap, we should spend a little bit more time or provide a service where if the physician can't provide the time, at least a nurse or a nurse practitioner or an aide can help, or a smoking cessation clinic can help in discussing these matters with the patient. And it is always useful to, every time when you see the patient, to discuss smoking, to discuss the cardiovascular effects of smoking, and to discuss stopping smoking. It has been shown that if you continuously repeat this to the patients, this will help them in quitting smoking. And again, we assume that the patients know all of this, and therefore we as practicing physicians do not do this all the time. Thank you.
Dr. Koji, you want to
Okay, thank you very
comment on
much.
that?
In addition to Dr. Weil Almahi's comment, I would like to stress that some of the smokers with nicotine dependency know the risk of cardiovascular diseases by smoking, but they are unable to quit smoking because of the nicotine dependency. We need more repetitive advice smokers to quit smoking. Even though we advise once, they will not be able to quit smoking. The nicotine dependency is not so easy to cure. We need a repetitive advice. Even though they refuse to quit smoking, every time they come to the hospital, we need advice to quit smoking. We need explanation of how dangerous tobacco is for cardiovascular diseases. Even though they know the risk, we need a repeated explanation. On the other hand, for younger patients or light smokers, we need more awareness on the risk of cardiovascular diseases by smoking. Mostly younger smokers are healthy and active and do not care about their own health so much. They should know the cardiovascular diseases such as myocardial infarction or cerebral infarction suddenly occur even though they are active and healthy. We need more awareness before the younger patients get into the nicotine dependency. Thank you very much.
Thank you, Dr. Koji and Dr. Weil, for the explanation. Cardiologists and healthcare professionals have a crucial role to play in reducing and preventing tobacco-related mortality. Dr. Koji, what do you think? So as a cardiologist, what do you think you can do to prevent the initiation of smoking and the relapse and to promote smoking cessation? What are your messages to other cardiologists and healthcare professionals?
Thank you very much for your question. The first thing I'd like to stress is that I previously described smokers as patients suffering from nicotine dependency. So we need a repetitive explanation. It's not so easy. So we need to keep advice to quit smoking. That is the first thing. And the second thing is that passive smoking will greatly affect cardiovascular risk. For example, very few cardiologists or healthcare professionals will ask non-smokers about passive smoking. For example, we should ask non-smokers, are there any smokers among your family members living with you? If there is a smoker living with non-smoker, the risk of non-smoker will be the same with the smokers. So we need to ask non-smokers to advise the smoker to quit smoking living with non-smokers. That is very important, but very few cardiologists or healthcare professionals are advising non-smoker about the passive smoking. Also, the cardiologist and healthcare professional should know how policy such as raising tax or passive smoking law and tobacco industry interfere are important. The cardiologists and healthcare professionals are mostly involved in the patient care, but they should also be involved in the policy making, and also at least they should know how important these policies are to stop smoking. Thank you very much.
Maybe let's touch base on the topic of e-cigarettes. Heated tobacco and other novel tobacco products loosely represent an emerging class of tobacco products marketed as reduced exposure or modified risk products. I want to know from Dr. Koji and Professor Monica, what are the effects of these products on cardiovascular systems? Maybe Professor Monica can answer first.
Since smokeless tobacco is now used in more than 100 countries, it is no more a tobacco use problem of only Southeast Asia region, but it is becoming a global problem. With 6 million deaths and 258,000 lives lost from ischemic heart disease, which can be attributed to smokeless tobacco use, it is important that we discuss smokeless tobacco and cardiovascular diseases. So I will first talk about what is it in the ingredients. So toxic metals such as cadmium, nickel, and other additives that make smokeless tobacco more palatable. They are reported to have an adverse effect on the cardiovascular system. Also, use of smokeless tobacco has been found to be equally deleterious as use of smoking forms of tobacco. Mostly smoking forms of tobacco and cardiovascular disease has been well explained, and there is a lot of evidence, as has been also explained by my earlier speakers. But smoking and chewing tobacco have an equal and comparable adverse effects on lipid profile, and they raise cardiovascular risk in the same proportions. Also, smokers and smokeless tobacco users have both been found to have higher value of cardiovascular, very low density lipoprotein, cholesterol, triglycerides as compared to non-smokers or non-tobacco chewer group. So we need to understand that it is contributing to all the issues of cardiovascular diseases which are related to smoking. So tobacco chewers again have significantly higher systolic blood pressure, diastolic blood pressure, resting heart rate, and when we see this in comparison to the non-users group. Chewing tobacco has also been associated with myocardial infarction with the odds ratio of about 2.23. So those who are chewing tobacco have more than twice the risk of getting heart attack as compared to non-tobacco users. So this evidence is now very clear. Multiple research studies have proven that effect of chewing tobacco has been found to be undiminished even after adjusting for diabetes, abdominal obesity, hypertension, exercise, and diet. It is more importantly also very useful to understand that discontinuation of smokeless tobacco use has again similar benefits as smoking cessation has. So discontinuation of snus, for example, after a myocardial infarction episode has been associated with nearly halving the mortality risk, which is similar to the benefits which are associated with smoking cessation. So as we talk about novel tobacco products or new tobacco products, we need to understand that smokeless tobacco products also have now been shown to have deleterious impact on our cardiovascular health. Thank you.
Dr. Koji, you want to comment on the e-cigarettes?
Okay, thank you very much. Heated tobacco products and e-cigarettes contain nicotine are definitely not safe, harmful, even though we do not exactly know how harmful they are. They are harmful same level with classic tobacco or much harmless compared with the usual cigarette. We do not know exactly, but we can conclude that they are not safe. There are many chemicals contained in tobacco smoke. Some of the chemicals, the level is reduced in new tobacco products. However, most of the chemicals, the levels are same. In case of nicotine, the level of nicotine contained in the heated tobacco products or ends, e-cigarettes contain nicotine, are similar with the level of classic tobacco or cigarettes. We are hypothesizing that the cardiovascular risk by new tobacco products will be around the same by the classic tobacco cigarettes. Actually, there is a paper after utilization of the new tobacco products such as HTP and e-cigarette, the blood pressure increase and the blood flow decrease in a similar way with classic tobacco. So definitely we can say that these new tobacco products are not safe, even though we do not know exactly how harmful they are. So we should make a conclusion these products should be restricted. Actually, in 2019, the WHO declared that HTPs, heated tobacco products, should be treated as a tobacco product. And should be subjected to the regulation by FCTC in a similar way with classic tobacco. So we should increase the more awareness on that HTPs are not safe and harmful. Thank you very much.
Professor Monica, so do you agree that the smokeless tobacco can be something in the market that is effective for smokers who wants to quit, or you don't agree to that?
So I am not a supporter of harm reduction strategy. I don't believe that smokeless tobacco products or the heat not burn tobacco products or e-cigarettes for that matter can be used as cessation products. First, there is no evidence to show that they are pharmacological treatment or they are cessation products. Definitely, there have been some evidence saying that use of smokeless tobacco product reduces the risk of lung cancer. But as I have explained, there are multiple other health effects which are associated with these new products which are being introduced into the market. So they are definitely not safe products. If someone has to quit, there are pharmacological treatment, there are other methods of quitting, which includes cessation. There are methods of counseling. People quit cold turkey. So there are very many other tried, tested, and scientifically proven cessation methods as compared to these non-proven methods which are being propagated by the manufacturers of these products.
Okay, thank you. Same question to you, Dr. Koji. So do you agree that the e-cigarettes can be used as an effective smoking cessation?
Thank you very much. Actually, the nicotine is a chemical agent used for pharmacotherapy. So in case of Japan, the e-cigarette containing nicotine is prohibited by the law of the drug administration. So if we are going to use new tobacco products for smoking cessation, these products should be subjected to the drug administration law. So these products should not be sold at the usual department store or convenience store. Should be sold only at the pharmacy by prescription by medical doctors. That is the first thing. So the tobacco product, if we're going to use this for the treatment, this should be subjected to the law of drug administration. And secondly, most of the new tobacco product users originate from classic tobacco users. So mostly usual tobacco users change their type of tobacco from classic one to new one. So I believe such person will be able to quit smoking rather than change into new tobacco products if we claim that new tobacco products are not safe. The reason they change their tobacco types from classic one to new one is that they are believing that the new tobacco products are much safer, but actually these tobacco products are not safe. So if we stress more that new tobacco products are harmful, this is a fact that people who will use new tobacco products will decrease. This will promote health. Thank you very much.
Thank you, Professor Monica and Dr. Koji. Moving on to our next topic, tobacco, COVID-19, and cardiovascular health. In light of the COVID-19 pandemic, many organizations involved in cardiovascular disease have stressed the importance of smoking cessation. I'm going to ask this question to Dr. Weil. Can you explain what are the relations between tobacco use and COVID-19 and cardiovascular disease, and why should smokers quit now more than ever? What are the risks for smokers and cardiovascular disease patients in terms of COVID-19 disease severity?
Thank you. As you know, the last 1.5 to 2 years, we continue to get new data on this subject. So this is a moving target. However, this is what we know now. Let us start with smokers who have comorbidities. So if you are a smoker and you have heart problem or heart disease, or you have high blood pressure, or you are obese, or you have lung disease, it is well known now that if you catch COVID-19, that you will have a higher risk of hospitalization intensive care, intubation, and death. So it is well known that smokers with comorbidities will have worse outcomes than somebody without a comorbidity. Now, if we look at smokers who have a lung disease as well, they will also have worse outcomes. There's also some data, although it has been controversial because of some data that was sponsored by the tobacco industry, but we as physicians believe that even if you're a smoker without any comorbidities, you will still also have a worse outcome than somebody who does not smoke. So as you said, this is the best time to stop smoking, not only because of the cardiovascular effects and all the complications that we have discussed, but also because of COVID. So this is the best time to stop smoking. Unfortunately, some people have found it very difficult to stop smoking in this pandemic, and these people we have to try and support, as because of lockdown, stress, depression, loss of livelihood, and some people have gone back to smoking or increased smoking. And this is where we as physicians and other healthcare people should try and help these people stop smoking, because this is the best time to stop smoking. Thank you.
Thank you, Dr. Weil. Dr. Koji, you want to comment on that?
Thank you very much. Mostly well described by Dr. Weil Al-Mahid. And if I could add, the COVID-19 virus, SARS coronavirus 2, will bind to the receptor in the endothelium and cause damage and inflammation and increase the thrombogenicity. So in COVID-19, the risk of cardiovascular diseases such as myocardial infarction, cerebral infarction, and pulmonary infarction increases a lot. In addition, the smoking will greatly affect the vessel wall, induce inflammation, and increase the thrombosis. So that is the reason why the smokers will be in the higher risk in COVID-19. In addition, smoking will greatly affect the immune ability, will decrease the immune ability. After the vaccination of COVID-19, antibody titer generated is much less in smokers compared with non-smokers. So presumably antibody generated after the infection will be less in smokers compared with non-smokers. That is another reason why smokers are in high risk in COVID-19. And after stop smoking, the immune ability will recover just only 2 or 3 weeks after quitting smoking. So that is the reason why we need to stop smoking during the COVID-19 pandemic. Thank you very much.
Thank you for your explanation, Dr. Koji. Next question, Dr. Weil and Dr. Koji can answer again. Smoking cessation is one of the most effective interventions to reduce cardiovascular mortality. What are the benefits of smoking cessation? How effective is smoking cessation compared to other methods of intervention?
Yes, smoking cessation is a very important part of the control against tobacco. And unfortunately, it's not available in all areas and all hospitals. Not a lot of people have been trained in smoking cessation. Medications and the techniques used in smoking cessation are not widespread. However, smoking cessation is a very important part of armamentarium against smokers. And smoking cessation clinics have been found to be extremely effective, whatever techniques they use, whether it's drugs or psychological or other techniques. They are very effective in stopping smoking. Obviously, if the patient is motivated, the chances of stopping smoking are much higher. And so once you stop smoking, as has been mentioned by Professor Eduardo, your risk of heart disease and complication drops tremendously within the first few years. So it's definitely very beneficial to stop smoking, even if you've had an event. Your risk drops down to nearly normal levels at some point, but at least in the first 2 years may drop by more than 50%. Thank you.
Thank you very much. And definitely smoking cessation is effective to prevent cardiovascular diseases. If smokers continue to smoke, the beneficial effect of other interventions such as pharmacotherapy will completely disappear. So the smoking cessation is the first priority. we should increase the awareness of the smoking cessation therapy, even though in some countries the pharmacotherapy is supported by the government, in others not supported by the government and insurance not supported. But still the smoking cessation is cost effective. Just only 1 day of pharmacotherapy, the cost is similar, is one package of smoking. So even though not supported by the insurance, it's not so expensive. And also, if we consider the cost effectiveness, probably the smoking cessation is the highest cost effective way to prevent cardiovascular diseases. If we going back to the smoking cessation clinic, some of the smokers really like to quit smoking, but they are unable to do so because of the nicotine dependency. So even though the therapy is not supported by the government, some smokers will pay money to quit smoking because they really like to quit smoking, but they are not able to do that. Thank you very much.
Thank you, Dr. Koji. Dr. Weil, what do you think? How much resources do you think is dedicated to these interventions?
Thank you. Unfortunately, not as much resources as we would like are dedicated to smoking cessation, particularly in low and middle income countries. As I had mentioned earlier, first of all, we don't have enough people who are trained in smoking cessation, and this is something that we need to do. You do not have to be a physician to be trained in smoking cessation. All healthcare workers can be trained in smoking cessation. There aren't enough clinics in smoking cessation, and this is something that has to be developed, and this obviously requires resources, but it doesn't require as much resources as Dr. Koji said, because it just requires trained people and the availability of medications and other techniques. Unfortunately, as Dr. Koji said, some of the medications are not covered by the government or by insurance, and this is also a very big hurdle. So we need to have these medications covered by insurance to move forward. The other thing is, in some hospitals, major hospitals, smoking cessation is readily available. However, our physicians in those hospitals aren't aware of these availabilities, and we have to make our physicians aware of smoking cessation clinics. Some of them are not convinced, and we have to convince our physicians that these techniques do work. And so referrals to these smoking cessation clinics are not very high, and therefore we have to encourage more referrals to these clinics by our physicians, because they are not referring enough. Not every smoker is referred. Again, as we talked in the beginning, that the patient knows and the patient wants to stop but can't stop, or they assume that the patient does not want to go to a smoking cessation clinic, but you would be surprised if you offer this service to the patient may want to go. Obviously, as we discussed in the beginning, there's still a lack of awareness amongst patients and also amongst some healthcare workers about the effects of smoking cessation. And we need to inform our patients, increase patient awareness through the mass media, through social media, that smoking cessation does work. And obviously, as we said, this does require resources. And at the same time, we are against a well-funded tobacco industry, and we don't have, in some countries, the resources to fight back against them. Thank you.
Thank you, Dr. Weil. Yes, I think funding by coverage by insurance for getting smoking cessation treatment is very important. I think it has a major impact when smokers decide to quit using this treatment. Next topic will be the roadmap on tobacco control. I would like to ask this question to Professor Eduardo. Can you explain briefly about the targets and objectives of the WHF roadmaps on tobacco control that was issued in 2015?
The World Health Federation roadmaps are guidance on reducing premature mortality from cardiovascular disease. The roadmaps are a strategy for improving cardiovascular health by translating existing knowledge and addressing barriers and presenting solutions in three priority areas: secondary prevention, tobacco control, and hypertension. The WHF roadmap are aimed to help countries, community, and stakeholders to accelerate actions to prevent and control cardiovascular disease. They are developed in the wider framework of the WHO Global Action Plans for Ncds. This Global Action Plan has some main objectives for 2025, that they are 25% reduction in premature mortality from cardiovascular disease, cancer, diabetes, or chronic respiratory disease, at least 10% of reduction in the harmful use of alcohol, a 10% of reduction in prevalence of insufficient physical activity, and 30% relative reduction in mean population intake of salt, and a 30% reduction in prevalence of current tobacco use in persons older than 15 years old. Regarding WHO tobacco roadmap objectives, they are first mobilizing a broader and stronger multisectoral support for implementing the WHO FCTC, as well as to increasing investment in tobacco control, and third, making tobacco control as a core part of the cardiovascular agenda. It also seeks to simplify the logic of FCTC implementation for audiences that are not public health specialists. The tobacco roadmap is based on the WHO FCTC main disposition, and the FCTC itself provides a detailed roadmap of evidence-based policies to reduce tobacco initiation, increasing quitting, and protecting people from secondhand smoke. The WHO tobacco roadmap charts priority intervention for implementing the FCTC, identify obstacles or roadblocks to the FCTC implementation, and indicate paths for bypassing this obstacle. This roadmap uses graphics to explain what FCTC implementation is and how it leads to reduction in cardiovascular mortality, introducing the basics to this not specialized audience. So, the roadmap provides a path. Now we should push our leader to embark on this journey.
Thank you for your explanation, Professor Eduardo. Next, I want to go to Professor Monica. I want to get your thoughts on this. The WHF roadmaps highlight some series of potential roadblocks to progress, and at the same time, it highlights also a series of potential solutions. Can you show us some of the examples of the potential roadblocks as well as the potential solutions to these challenges?
Sure. So the WHF roadmap on tobacco control did identify a series of potential roadblocks. So in spite of effectiveness of these tobacco control policies, implementation and adaptation of the WHO FCTC in majority of the countries have been varied, and that is where the greatest roadblock has been. Not many people in the countries which have even ratified and implemented FCTCs, they have not been protected by many measures of the treaty. And one example is the most effective measure, which is taxation, that has the lowest rate of implementation. So that is one roadblock, that countries which have gone ahead and embraced FCTC, the governments still have not raised the taxes of tobacco products enough to be able to hit the demand of tobacco products by raising the prices so much that people do not initiate tobacco use and they do not continue to use tobacco. Other barriers have been lack of political will, inadequate financial and technical resources for implementation and enforcement of tobacco control. There is weak mechanism for coordination between health and the non-health sector. As we all know that tobacco control has majority of its measures which lie outside the health sector, whether it is taxation or it is supply side issues or demand side issues. Many of these have to be governed by other sectors. It may be in Ministry of Finance, it will be in Ministry of Labor, Ministry of Agriculture, Ministry of Environment. So there are very many other players who have to take up leadership position in tobacco control, and they have to understand the connect that they have with what their domain is with tobacco control. And that is where the health ministry has to do a lot of advocacy to bring their counterparts in other ministries to support tobacco control. So that has been a major roadblock. Tobacco industry interference, which is the Article 5.3 of FCTC, that has been identified to be another roadblock where even if the countries are wanting to implement Framework Convention on Tobacco Control and come up with strategies, they have not been able to put effective policies because there is industry influence on bringing about stricter policies or implementing stronger policies. So this has been another roadblock which has been identified. And when these roadmaps were adapted by some countries, like it was adapted in India by us, tobacco industry interference did come up to be an important barrier that is not letting effective policies be implemented. Also, tobacco industry interference comes through corporate social responsibility programs because that is where they are able to manipulate public opinion through media, front groups in favor of what they are promoting within the government and through policies. Also, as I mentioned about poor intersectoral coordination, one area for cessation is the weak health system capacity, which also needs to be built when we talk about tobacco control and tobacco cessation. So these were some potential roadblocks, and on the research side, the roadblocks that have been identified are lack of reliable data and information system. This can be country specific. This was identified in India. And also the need to have the capacity to collect, analyze data, and communicate the information to policymakers as well as to the community has to be something which has to be built in the whole tobacco control program of a country. So having identified the barriers, there were potential solutions to these challenges which were identified by stakeholders when we had stakeholder consultations, but also identified in the roadmap. They have been, number one, to confront the tobacco industry interference, that is Article 5.3 needs to be effectively operationalized, limiting government interaction with the industry, ensuring transparency of interaction when they have to talk with the industry, discourage when possible regular activities described as socially responsible, ensuring that international organizations and networks do not collaborate with the tobacco industry, and also monitoring and exposing the tobacco industry with tobacco control policies. Second solution was galvanizing political will. So there have to be regular activities to develop active movement to broaden the base of support for these alliances in countries which are working on tobacco control, forming government civil society partnerships so that accountability and transparency of tobacco control program and policies is ensured, bringing in public-private partnerships very carefully, ensuring there is no conflict of interest, establishing sustainable financial resources to advocate for higher tobacco taxes to ensure that the proportions of returns invested in implementation of tobacco control is sufficient, and fostering intersectoral coordination. So we need to build capacities in the countries so that non-health sector is supportive of tobacco control. So the health in all policies, which was a terminology adopted and promoted by WHO, is something which applies very well to tobacco control. Strengthening health system capacity to treat tobacco dependence is an area which many developing countries still need to work on and need support, both in terms of research as well as in their interventions in the health system. Last but not the least, we need to collect reliable data and create information systems which are robust so that we can assess the impact of these policies as they are implemented and be able to see whether we are meeting our tobacco control targets which have been set for 2025 and 2030 under Sustainable Development Goals. Thank you.
Thank you, Professor Monica, for your thorough explanation. So basically, make noise is important. The community has to make noise for their rights. So that brings us to the end of our discussions. In a nutshell, we've looked at some of the main points. Firstly, tobacco use and secondhand smoke are seriously damaging the cardiovascular systems. It can cause coronary artery disease, stroke, and peripheral vascular diseases. The chemical from tobacco can damage the heart, blood cells, structures of the blood vessels, and increase blood pressure. Secondly, smoking is a risk factor for severe outcomes of COVID-19 patients. The COVID-19 pandemic has heightened the awareness of risks associated with tobacco use. Therefore, now is the perfect time for smokers to quit more than ever. Thirdly, cardiologists have a crucial role to play in preventing and reducing cardiovascular mortality by spending more time with the patients and understanding that these smokers are patients suffering from nicotine dependency. A lot of resources are still needed. Open more cessation clinics, increase availability of drugs, and coverage by insurance also needed. Lastly, we've looked at e-cigarettes and the smokeless tobacco and other novel tobacco products. Although with harm reduction, they still pose serious health concerns to cardiovascular systems. We have come to the last part of this symposium, which is the presentation session. Here to present the topic about conflict of interest in the tobacco industry and tobacco industry interference in science is Professor Monica Arora.
The topic I'm going to discuss is around conflict of interest and tobacco industry interference in science, because that is an area which is currently being seen as a real cause of concern among the tobacco control fraternity, but also among other public health experts, and now even overall in communicable as well as in non-communicable diseases, with COVID seeing the industry interference in the whole COVID pandemic. So I will talk about Article 5.3, but also I'll cite examples of how industry is interfering with science. So we have been talking about it earlier in our discussions, and it was identified as a major roadblock even in the World Heart Federation roadmap on tobacco control. So who is the tobacco industry? Many of us working in tobacco control know that they include manufacturers, distributors, importers, supporters. So basically anyone who is related to either growing, manufacturing, distributing, selling, and even their front offices. And many a times they are now expanding their support network, and their allies include scientists and lobbyists as well. Now we are seeing the whole harm reduction community also having close association with tobacco industry. So their public relations, advertising agencies, stakeholders are the ones who are their front offices, and just to be able to ensure that they are not in the glare of public knowledge that they are doing dubious activities, they use these front offices. What are the main forms of tobacco industry interference? So I did mention that one is they discredit proven science. They would question evidence, which is very, very apparent. In the beginning, they even questioned if tobacco caused cancers. So that is the level of denial that they make of scientific evidence, conspiring to hijack the political and legislative process, trying to use this as a roadblock to any new policy development that a country undertakes, intimidating governments with litigation or the threat of litigation, exaggerating the economic importance of the industry, how they are providing employment to so many people in the country, and at the same time how they are contributing to the exchequer through taxation and other means. They also manipulate public opinion to gain the appearance of respectability by doing useful work to be shown as CSR activities, which is corporate social responsibility activities, and also faking support through the front groups. When it comes to anything which may disregard their image, they bring in these front groups. Tobacco industry tactics have expanded exponentially recently. They fund scientists to push pro-tobacco studies, and also they sow confusion about legitimate science. They create scientific forums to disseminate pro-tobacco studies, and they misrepresent the cost of regulation, compliance, and its economic impact. Recent example has been around tobacco use and COVID. Many of the research studies have been showing, and the clear understanding that we all heard today as well is that smokers are at a greater risk of COVID adverse outcomes if they are hospitalized as compared to non-smokers. But some research studies dubiously have been showing that smokers actually may be protected. Smoking may have a protective effect. In fact, some of the research studies which may have quoted something different were misrepresented by the industry in the media to propose that smoking can actually be helpful to avoid COVID. So that is the level of fudging of research evidence that is undertaken by the industry. There are legal tactics where they provide draft policies which include pro-industry language. They promote policies that divert resources or funds away from tobacco control. They divert focus onto less effective tobacco control measures such as youth access restrictions. They would like to do more awareness, saying that yes, we should tell children that tobacco is harmful and they should not use it up to the age of 18. So those are the kind of messages they try and give to the community. And deterring legislation by pressing for adoption of voluntary codes or weaker laws. So they try and resist anything which is more regulatory and would want to do things which are self-regulation by the industry. They have in their allies hospitality industry, advertising, packaging, transport, those who receive tobacco sponsorship. So they do fund all of these to be able to expand their network of supporters. Also, public relation tactics include tobacco industry's fake support, establishing front offices, engaging with third parties, publicly acknowledge the risk of tobacco use but not accepting any accountability, bringing in farmers' issues whenever effective strategies are being discussed, showing that the ultimate impact would be on poor farmers, and promoting safer products and conducting CSR activities so that they are seen to be very responsible industry. This is an example of industry-funded epidemiological analysis of large data sets that were used to argue against an epidemiological association between secondhand smoke exposure and cardiovascular diseases. But ultimately, the analysis were seen and the methodology was seen to be flawed with having exposure misclassified. So usually they do publish such research studies, they get wide media attention, and then they would be refuted by experts in epidemiology on the ground of having methodological errors or data being not comprehensive that they have used and not using representative samples and the like. But they get their share of success that they wanted of misleading the community and the policymakers on evidence. So there is definitely a direct and irreconcilable conflict of interest between the tobacco industry and public health policy making. So that is the whole basis of Article 5.3 of the WHO Framework Convention on Tobacco Control. It aims that countries or the parties to WHO FCTC implement Article 5.3 so that they can protect their public health policies from tobacco industry interference. And they make recommendations on 8 issues: raising awareness about the harmful nature of tobacco products, limiting interaction with the tobacco industry, rejecting any kind of government partnership with the industry, avoiding conflict of interest, requiring that information provided by the industry be transparent and accurate, and under this, any meetings that industry may so seek from the ministries need to be transparent, so they need to be recorded or they need to be conducted in presence of public so that the whole interaction is transparent. Denormalize CSR activities, no preferential treatment to the tobacco industry, as many countries do give subsidies to the tobacco industry and to the tobacco crop. Treat state-owned tobacco industry in the same way as any other tobacco industry. So trying to disinvest in tobacco and also to be able to denormalize the whole smoking and tobacco use as a practice. However, we also see that there is a conflict of interest under Sustainable Development Goals. On one hand, we have SDG 3, but SDG 17 is directly in conflict with the FCTC implementation target of SDG 3 because it does allow for public-private partnership to mobilize and share knowledge, expertise, technology, and financial resources. This is being exploited by the industry to get on several development programs. So they would not directly partnership with health programs, though they do that as well. But they start partnering with education programs, they try partnering with development programs and trying to make big investments in the government schemes and programs to be able to show how responsible they are and are contributing to the welfare of the country and development activities. Also, their whole diversification of the tobacco industry into food industry and many other FMCG products makes it very, very difficult to have clear guidelines of conflict of interest because the whole boundaries are getting very diffused as they come in as a tobacco industry, but they can sit on food policies because they are a food industry. And through those connections, they try and influence policies in every other field. So these are important issues which are coming up now in the current environment. With COVID-19, we very clearly saw how the tobacco industry started becoming an important partner. So they started doing webinars to say how healthy respiratory system can be developed during COVID-19, whereas their own products are making people vulnerable to have adverse outcomes of COVID-19. So they were seen to be very important player with their front offices, and since they are an industry, they usually use industrial chambers to be able to reach out to very influential medical doctors, professionals who are well renowned in the country to be able to participate on their webinars. And many a times these people do not realize that there is industry behind conducting these webinars. So seeing that industry was playing a very important role during COVID-19 by providing PPE kits or being able to support other rehabilitation work of COVID-19, NCD Alliance during the World Health Assembly has also released advocacy briefing where they highlighted how tobacco industry has been exploiting the pandemic to promote unhealthy products and to promote weaker regulations. And some of these documents are available online, and the civil society organizations did ask for action to the governments and WHO to identify, avoid, and mitigate conflict of interest in health decision-making processes. This is another example of WHO Civil Society Working Group on NCDs, which released its statements at the World Health Assembly, mentioning very clearly in it that in the midst of public health emergency of international concern, companies that produce harmful products such as tobacco, alcohol, and sugar-sweetened beverage continue to spread misinformation and deny the link between harmful effect of their products and COVID-19. So these statements have been very, very important in being able to inform the stakeholders and governments on being very cautious about their partnerships and accepting these donations coming from the private sector, especially if it is tobacco, alcohol, or food industry. Moving on, World Heart Federation has recently announced its new conflict of interest policy on tobacco. So this policy was announced on the World No Tobacco Day this year. It adopts and implements a conflict of interest declaration for speakers and delegates at online and in-person events so that the science produced by World Heart Federation can be protected from these influences. And even groups like Philip Morris's Foundation for Smoke-Free World has been barred. Anyone who is associated with this foundation is barred from participating in the Congress or virtual events. Here is joint statement by the 4 leading cardiovascular organizations on how they need to strongly regulate tobacco industry marketing and ensure that tobacco industry interference is minimized. So having cardiovascular organizations and associations take up such joint opinion pieces at global level is very, very important for tobacco control, because they are seen to be the most respected voices in the countries and by the governments. Also, World Heart Federation did publish this statement about PMI's Foundation for Smoke-Free World, that despite funding a foundation that claims its goals as ultimately eliminating smoking worldwide, PMI continues to invest billions of dollars in marketing cigarettes worldwide. So again, time and again, countering these efforts by the industry, by foundations is very important. And I would now just like to highlight that monitoring Article 5.3 implementation at each country level is also crucial. This is just an example of what we started in India in 2018, and we are doing this monitoring every year using Southeast Asia Tobacco Control Alliance's index tool, and this helps us see how the government is performing on Article 5.3, and we see that a higher score here means that the tobacco industry interference is high in the country, but over the years we are seeing with this monitoring this score is reducing. If you see, score was 72 in 2018, came down to 69 and 61 in 2020. So we have been publishing these reports, and such kind of monitoring exercises become very important for the country. And also then CIATCA releases global reports where we can see the country position as compared to other countries. So this becomes an indication for the government to see that they should start reducing their score to be able to become a compliant country. So just to conclude, cardiologists and heart associations have a very important role in implementing Article 5.3. They can be involved in public interest litigations, or they can initiate public interest litigations if they see industry interference. They can do awareness and sensitization as well as one-on-one meetings on ensuring there is policy coherence, especially the multi-sectoral action plan on NCD prevention and control, because that has health and non-health players on it. Identify, monitor tobacco industry interference and report to appropriate authorities for action. Develop coalitions and partnerships keeping conflict of interest in mind. So even having the conflict of interest policies in the association activities and membership. And last, I would like to highlight that membership on expert group and media advocacy is an important area that cardiologists can handle, because they can write op-eds and editorials to be able to make an impact and underscore that governments need to comply with Article 5.3 of FCTC and avoid tobacco industry interference in all public health policy making. Thank you.
Thank you, Professor Monica, for sharing your insightful and very informative presentation with us. So you will make available your presentation materials to the organizing committee, so all the participants who wants to get your presentation can contact the organizing committee. Finally, we have reached the end of our session. Professor Eduardo Bianco will give a closing remark. But before that, on behalf of the World Heart Federation, I would like to say a warm thank you to all the speakers, Dr. Koji Hazagawa, Dr. Wael Al-Mahmed, Professor Monica Arora, and Professor Eduardo Bianco for sharing their thoughts on cardiovascular health and tobacco control. To all the participants, thank you for joining this session. We look forward to seeing you in person in the next APEC conference. Eduardo?
On behalf of the World Heart Federation, I would like to thank our moderator, esteemed speaker, and panelists for their inspiring contribution. I would also like to express my deepest gratitude to all participants for attending our symposium. As you have heard, tobacco is responsible for considerable cardiovascular morbidity and mortality. It is undeniable the single largest preventable cause of disease and death globally. Tobacco harms the cardiovascular system via a multitude of pathways. As highlighted, nearly 21% of all coronary heart disease death can be attributed to tobacco use and exposure to secondhand smoke. Unfortunately, despite the known harm of tobacco to heart health, smokers are often unaware of this link. However, effective solutions such as pictorial warnings can be employed to address these knowledge gaps. In the age of COVID-19, we must accelerate our effort to make our community smoke-free and encourage smoking cessation now more than ever, as both heart disease and tobacco increase the risk of severe COVID-19. Smoking cessation has been proven to be the single most effective intervention for the reduction of cardiovascular disease mortality. The health benefits of quitting are significant and can be observed in the short and the long term. In recent years, smokeless tobacco, as well as other novel products, have become increasingly popular. As discussed, these products are far from harmless and are associated with an increased risk of cardiovascular morbidity and mortality. Please allow me to reiterate, all forms of tobacco are harmful. There is no safe levels of consumption and exposure. The World Heart Federation roadmap for tobacco control highlights common challenges and solutions encountered in tobacco control. As demonstrated, the roadmap can be adapted and implemented effectively in different settings. Governments have a legal responsibility to protect the health of their population and contribute to reversing the tobacco epidemic. The tobacco industry has a long history of systematic, deliberate interference in health and regulatory science. By distorting scientific evidence with biased and deceptive industry-funded research, it has sought to create an unnecessary and harmful confusion and controversy in the minds of the public and the policymaker for the sole purpose of protecting his profits. The industry has recently redoubled his effort to reintegrate itself in the scientific and policy communities with his exploitation of the pandemic-related corporate social responsibility endeavors and his funding of media, public relations, and dubious research. Health and scientific organizations have a duty to act and protect both public health and the integrity of scientific research. Lastly, cardiologists and other healthcare professionals have a crucial role to play in preventing and reducing further tobacco-related mortality. Given the current level of evidence on tobacco and cardiovascular health, as well as the health benefits of smoking cessation, failing to offer cessation services to patients with heart disease could be considered clinical malpractice or negligence. Cardiology societies should train their members in smoking cessation and promote or even drive tobacco control advocacy efforts. The World Heart Federation and his members believe in a world in which cardiovascular health for everyone is a fundamental human right. We are making great efforts to turn this vision into reality for all, and we remain committed to the creation of a tobacco-free world. Thank you for joining us today and for making this event a success.
Thank you very much, all excellent speakers and the moderator. Among the difficulty in accommodating the speakers who are in the different time zones, you all can still make this wonderful symposium through the video recording. Thank you so much. These sessions had point out so many important issues in terms of cardiovascular health, especially on the effects of the tobacco products on the cardiovascular health, not only for the traditional tobacco products, but also the e-cigarette and also the smokeless, tobacco too. And also at the times of the COVID pandemic, we can see that there are the synergistic effects of the tobacco use and COVID-19 on the cardiovascular health. And also at the end of these sessions, it raised the concerns of the role of the healthcare professional to address the tobacco use as related to the cardiovascular health issues. As we come to the end of the Symposium 3, in terms of the role of cardiologists and cardiovascular healthcare profession in tobacco control, I would like to thank all participants who are still here with us. I hope you all enjoy these sessions and also many more sessions that this conference will offer to you in this 2 days conference. Thank you very much.